All right, so welcome to our university seminar series with the GW Institute for Brain Health and Dementia on addressing dementia across the public health spectrum. Today, we have a wonderful speaker, Dr. Claudia Suemoto. She's an Associate Professor of Geriatrics at the University of Sao Paulo Medical School. She obtained her PhD at the same institution and focused on the association between dementia and atherosclerosis using morphometric measures and autopsy samples. She also has a master's degree in epidemiology and a postdoctoral fellowship from Harvard T.H. Chan School of Public Health. She is currently one of the coordinators of the Brain Bank of the Brazilian Aging Brain Study Group, which is the largest brain bank in Latin America. Dr. Suemoto is also works as an epidemiologist at the Longitudinal Study of Adult Health, where she investigates risk factors for cognitive impairment and decline. She received the L'Oréal UNESCO for Women in Science Award in Brazil in 2016 and the International Gerontology Award in Biomedical Science in 2022. So we're extremely lucky to have her speak for us today. Take it away.
So good afternoon, everyone. First of all, thank you so much for the invitation to be here. I would like to thank all the organizers from the Institute for Brain Health and Dementia for the opportunity to talk today. And I would like to also thank you for being here during this presentation. So I'm going to talk about opportunities for dementia prevention in Brazil, basically, because I'm going to show basically data from here. And at the end, I'm going to talk a little bit about some of the studies that we are conducting in Latin America too. So I don't have any conflict of interest to declare regarding this presentation. And the outline for this presentation, first of all, I'm going to give you some numbers to show the importance of dementia in Brazil. Then we're going to use the brain bank to explain the causes of dementia in our country. Then I'm going to move on to talk about risk factors. And I later will talk about dementia prevention, the potential for dementia prevention in Brazil. And then I'm going to talk for the Latin fingers, and then we are going to conclude. So regarding the importance of dementia in Brazil, I think you all know that currently most people with dementia, around 52%, already lives in low and middle income countries. And by 2050, this number is going to increase. And about 70% of people with dementia are going to live in countries like Brazil. So, and when comparing all the regions in the world, Latin America stands out with the higher prevalence of dementia. 80.6% of people older than 65 years old are supposed to have dementia in our country. So it's already a problem of low middle income countries, and it seems to be even more important in Latin America. And to talk about numbers of the prevalence of dementia in Brazil, I'm going to use a study that is called ELSI Brazil. It's the Brazilian Longitudinal Study of Aging. This is started in 2015, and it's following 9,400 people that are representative of the Brazilian population. So here you see a map of Brazil, and this study sampled people around the country. You can see that they really try in all states to represent the socio-demographic profile of the Brazilian population. And the good thing about the ELSI Brazil is that it's a sister study of the HRS, and this is also being used for cross-country comparisons. For example, we are doing currently a comparison between Mexico using the MHAS and Brazil using the ELSI Brazil. And of course, you can do in the future other studies comparing even to the American population. To determine the numbers of people 60 years or older that have dementia in Brazil, we performed a study that was conducted by the neuropsychologist Laís Bertola. She's currently a postdoc fellow in our group. And what we did is that we select a normative sample around out of these 9,000 people. There are around 900 of them that are super normal. They don't have any memory, any cognitive complaints, any history of neurological disease, no history of depression. They don't drink too much alcohol. They also didn't have hearing and visual impairments, so they are super normal. And using their cognitive tests, she in fact developed norms based for age, sex, and education, and then applied these norms for the whole sample. And she could compare who deviates for the predicted normative score and compared to the actual score. And for this, with this predicted score and the normative sample, she created these scores, and those that were minus 1.5 standard deviations below the normative score were considered of having cognitive impairment, and they are considered to have dementia if they have the cognitive impairment plus functional impairment measured by activities of daily living. Using these two data, she estimated that 5.8% of people 60 years or older in Brazil have dementia in 2019. This is equivalent to 1,757,000 people with dementia in Brazil. And this prediction that she published this year is very similar to GBHB forecasting for dementia. They did this also for Brazil, based in small studies that we have for prevalence studies, mainly on the southeast of Brazil. And their prediction is close to hers. And they estimated that 1,849,000 people have dementia in Brazil in the same year. So this is also from Dr. Bertola's work. She shows, as expected, that the prevalence for dementia that is represented here in the lower graphic increases with age, of course, and it's estimated to be around almost 40% in people 9 years or older. The prevalence is slightly higher for women, as described previously. And this is going to be a problem in the future because, as you know, Brazil is facing a very fast aging of its population. Currently, it's estimated that the proportion of people that are older than 60 years old is going to double in less than 30 years. And this is very different, for example, from Europe, where this the population of 60 plus double in a very slower pace in more than 1 century in some countries. Another, regarding, it's not only prevalent, but also there are some studies that we conducted estimating the incidence of dementia in Brazil. This is a little bit more complicated because it implies that you have to evaluate a population on the baseline and then follow them. This is a work that we have assistance from Professor Melinda Paulo from your university, and it's the doctoral thesis of Carolina Cesar, and she estimated a 5-year incidence of dementia in the Tremembé city, the city that the study was conducted, of 26 new cases of dementia per 1,000 person years during the study period. And here we can see the increase of the incidence of dementia, also very exponential with advancing age, as described previously. And if you review this graphic to compare the incidence with other studies conducted mainly in Latin America, and you can see that in Brazil, in Tremembé at least, the incidence is is in the higher end compared to other studies. So one thing that the GBHD did is not only estimated the amount of people that have dementia in 2019 in Brazil, as I said to you, it's 1.8 million, but they also forecast how many people would have dementia in 2050. And they estimated that almost 6 million people would have dementia in Brazil in 2050. And this is 206% increase. So we need to be prepared not only for the case that we have now, but the fast increase that we're going to face in the next 25 years. And the only thing that we can do, at least by now, is to prevent dementia. And one thing that is also important to mention is not only dementia is very prevalent in our region, but it can start 10 years earlier in low-middle-income countries compared to high-income countries. And I highly recommend it for you to read this editorial from Elisa Rezende from Brazil too, where she explains why dementia starts so early in low-middle-income countries, probably due to the low education and the high burden of cardiovascular disease. And if you think about the natural history of cognitive function, it's something that you build not only in your adulthood, but it starts at birth. And every person has different levels of maximum cognitive function that usually is achieved by the third decade of life. And then you have as low as decline. But if you have education, implies that if you have higher education, you're going to have higher cognitive function. On the other hand, if you have more cardiovascular factors and you have cerebrovascular disease, you're going to have a faster cognitive decline. As many of you know, currently Alzheimer's disease and dementia are already the most important cause of disability in high-income countries. In our region, it's the 10th cause, but with the age of the population, we estimated that it's going to be one of the most important causes of functional disability too here. So dementia is important in our region. It's going to be very important in the next few years. But I also would like to show some data about the cause of dementia in our country. As mentioned before, I work for the Biobank for Aging Studies. I coordinate the activities here. And I'm in a city that's called São Paulo. It's a city of almost 15 million inhabitants. And for you to have an idea about the amount of people that died here in 2019 was around 78,000 people this year. And if you die from natural cause, from non-traumatic cause of death, but the medical staff doesn't know the cause of death, you are obligated to go to autopsy to determine the cause of death. And our São Paulo Autopsy Service performs around 14,000 autopsies per year because of this mandatory need to establish the cause of death. So around 18% of all deaths in São Paulo city goes through our autopsy service. And we collected cases since 2004 in our brain bank. When the family came here to follow the autopsy, to be here and wait for the death certificate, we asked for brain donation. And since 2004, we've been collecting brains, and we currently have around 3,700 cases collected. And now it's 1,700 participants with full neuropathological assessment. The demographics of our brain bank, the mean age is 74 years old. We have an equal distribution between sexes. 69% of our participants are white, and this is something that a little bit different from other brain banks. That means that 31% of our participants are Black. The mean education here is only 4 years. For you to have an idea, probably in the US it's around 12 years old, in Europe it's 16 years old, so it's a very low education level. And we have a high frequency of cardiovascular risk factors. Around 6% of our sample has hypertension and 27% of them have diabetes. Another thing that is different from our brain bank, usually the other brain banks around the world, they have mostly cases with advanced dementia because they are based on donations of patients with dementia and they die with advanced dementia. Since we collect brains from people that come to autopsy, most of our cases have normal cognition, around 6%, and the other 40% has different levels of cognitive impairment, since mild cognitive impairment to mild dementia, moderate dementia, or severe dementia. That's the percentage that we have. So we have the opportunity to study different levels of cognitive impairment. But what about the causes of before that? So to determine the cause of dementia, we perform a full panel of immunohistochemistry to determine the presence of some lesions. For example, we do immunohistochemistry for beta amyloid for neuritic plaques and neurofibrillary tangles to determine the Alzheimer's disease is present. You also look for lesions related to vascular dementia, has small vessel disease and lacunar infarcts, and also for cerebral amyloid angiopathy. We look also for alpha-synuclein and classify Lewy body pathology and TDP-43. Using this panel, we are able to determine the causes of dementia in our sample. And here we have a mosaic plot showing the levels of cognition, so normal cognition, mild cognitive impairment, and dementia. And here you have the different lesions that are present in the brains that we analyze it. Around 50% of our samples have lesions related to Alzheimer's disease, AD pathology, 35% have vascular dementia, and 13% have Lewy body disease, Lewy body pathology. If we compare to other cities from other countries, we have a high frequency of vascular dementia, which corroborates what I said before about the high burden of cardiovascular risk factors. And I would like to emphasize that we use a very conservative measure of vascular dementia. As some of you know, there is no consensus about how to classify vascular dementia. And we only use infarcts in strategic areas or very spread the presence of infarcts in at least 3 regions. But if you're going to use, if you use the criteria of also consider a moderate to severe small vessel disease, the frequency of vascular dementia in our country would be 49%, and it would be very similar to Alzheimer's disease. So that's one of the messages that I would like to give during this lecture, that probably vascular dementia is even more important as a cause of dementia in low-middle-income countries. Another thing that it's also described in other brain banks is that asymptomatic lesions are frequent. When we see most of our sample has normal cognition, clinical dementia rate equals 0, but around 35% of them have normal cognition and enough lesions to give some neuropathological diagnosis. So these people, they have something different, because although they have enough lesions to have symptoms they don't have, so they are resilient. And currently we are trying to understand a little bit more about cerebral resilience in the context of low education and high burden cardiovascular disease. And I hope we're going to have some results to show in the future. Another thing that is also important from neuropathological studies is the sense that neuropathological lesions are very, very frequent when we are seeing very old people. So here we have another study that we show the distribution of neuropathological lesions among people that are younger than 80 years old and 80 years or older. And you see that almost 75% of people, very old people, they have some degree of, they have a neuropathological diagnosis. In fact, they have enough lesions for the pathologist to give them a diagnosis. So currently, when you see some epidemiological studies saying that dementia prevalence increases exponentially and around 30–40% of people 80 years or older have dementia, that's true because they have enough neuropathological lesions to give symptoms for sure. And another thing when seeing very old people is that we need to open our mind for mixed dementia. Of course, we have poor vascular dementia, we have poor vascular dementia, Alzheimer's, poor Alzheimer's disease plus vascular dementia, but most of the time we have mixed dementia. And mainly when you're seeing very old people, we are seeing mixed dementia. This is another study that we published. It's a continuation of the previous mosaic plots showing the presence of mixed dementia, comparing people that are younger or older than 80 years old. And you see that here in the white bar are people that are very old, and in the black bar are people that are younger than 80 years old. And you see that mixed dementia, for example, Alzheimer's disease is vascular is almost is more than double the prevalence in very old people. Same is true for Alzheimer's disease and Lewy body pathology. Other, for example, Alzheimer's disease in TDP-43, and also it's true for the combinations of vascular dementia with Lewy body pathology, arteriophilic Crohn's disease, and carcinomas. So that's another thing that I would like also to emphasize, that in people that are very old, we are probably seeing someone, although they may have normal cognition at the time, they probably have some neuropathological lesions enough to give symptoms soon. And most of the time, we are not seeing one pathology, we're seeing a combination of them. Moving to the next part, I would like to talk a little bit about risk factors. We have some epidemiological studies that we are conducting. I'm going to focus mainly on 2 of our studies. So, as you know, there are some risk factors that we cannot do anything, at least in 2023. And we are talking about age, sex, race, and also about genetics, at least for now. And the most common genetic risk factor is ApoE, E4. But on the other hand, the list for modified risk factors are way longer. And you have low education, cardiovascular risk factors, other factors that are more rare, like sleep apnea, chronic inflammation, unhealthy diets. I'm going to talk a little bit about that. So there is a lot to change to prevent dementia, and that's probably the way to go in everywhere, but even more important in low and middle income countries. And another thing that I also like to say is that we have a cascade of events that happens until we have dementia. So in the beginning, we have a lifestyle that is not healthy, an unhealthy lifestyle, so low physical activity, unhealthy diet, low complex jobs, low education. And with time, these things are risk factors for cardiovascular risk factors like hypertension, lipidemia, diabetes, and this brings stroke and vascular dementia, what leads to cognitive impairment. So if we want to prevent dementia, we have to start early and change lifestyles, unhealthy lifestyles. And of course, when we are talking about a public health approach, and we want to change the history of dementia, for example, in Brazil, we need a population approach. We need to change the way that Brazilians or other populations are living. They need to practice more physical activity. They need to eat healthily, because this is what's going to prevent dementia many years later. And I think one of the most important risk factors in our region is low education. Here is another study that we published last year. And here you can see how different we are from high-income countries. Around 25% of our sample, and this is from the brain bank, has no formal education. They have never been at school. That's a lot. And most of our participants, around more than 50% of them, has 1 to 4 years of education only, and 15% of them has 5 years of education or more. This is really very different. And of course, this is the reflection of people that is around 74 years old on average at death. It's a little bit different now from the younger population in my country, but still we have lower education compared to high-income countries. And low education leads to unskilled jobs. So most of our sample has unskilled jobs, and very few of them, less than 10%, has skilled jobs. And in skilled jobs, I'm talking about jobs that requires that people have at least college. So most people don't have even college, less than 10% of them in our sample has. And the main aim of this study is to show measures of cognitive reserve. So we use proxies that are related to cognitive reserve, like education and occupation complexity. And we saw in our sample that even few years of education compared to no formal education is protective against, it's related to better cognitive abilities, even when we adjust the models for neuropathological lesions. We didn't find any association between occupation complexity and cognitive abilities in our sample, and this was found in other studies from Latin America too. And we believe that in our case, we have so few participants with skilled jobs that probably this reflects in our results. Another thing that I would like to touch on is cardiovascular risk factors, and for this, I'm going to talk a little bit about the longitudinal study of adult health we call ELSA Brazil. This is a study that starts in 2008, and we are following since then 15,000 people. At baseline, they are 35 to 74 years old, and we do in-person evaluation every 4 years. So currently we have data from 3 waves, and I'm going to show some of our results. The 4th wave is currently going on in all the centers. I forgot to say, this is a multi-center study that involves 6 major cities here in Brazil. And one of our studies investigate the association between cardiovascular health and cognitive performance. And it was based in the American Association Life Simple 7. I don't know if you have heard about it. So it's 7 metrics that were developed to give the population some guideline regarding smoking, physical activity, cholesterol levels, blood pressure levels, diet, weight, and also blood sugar. And based on people's score, we can classify the sample regarding their cardiovascular health. In Brazil, 53% of the sample, of the ELSA sample, has poor cardiovascular health, meaning that they have 0 or maximum of 2 risk factors that are under the ideal category. And only 80% have ideal cardiovascular health, meaning that they have 5 to 7 factors that are in the ideal category. That's really bad, but also if you want to see the cup half full, it's a huge opportunity for prevention. And as expected, people that have poor cardiovascular health have worse cognitive performance in memory, language, executive function, and of course in global cognition compared to people that have optimal cardiovascular health. This is a cross-sectional study that we published 2 years ago, but we conducted an update of this using longitudinal data. As many of you know, American Heart Association updated the Life Simple 7 to Life Essential 8. This new metric includes the 7 metrics that were evaluated before, but add sleep health as one of the measures for ideal cardiovascular health. And they also updated the way that we measure each metric. So now we have 4 behavioral factors that include sleep, diet, physical activity, and nicotine exposure, and 4 health factors: blood pressure, glucose, lipids, and body mass index. So we calculated these new metrics in the ELSA Brazil. This is a work that was done by Naomi Vidal, that is a postdoctoral fellow in my group. The ELSA Brazil is a very interesting study because most of the participants are middle-aged, so it's going to be a very good opportunity to investigate how they're going to age with time. But at baseline, they have 51 years old. The mean age is that. 56% are women and 43% of the sample are Black. This is the distribution of each metric and their classification. We can see that, at least in the ELSA Brazil, the main problems are diet. We have a very low, a high prevalence of low cardiovascular health regarding physical activity. The same is true for blood lipids. Other metrics are not so bad. And we find an association between life essential aid and baseline and cognitive decline during 8 years of follow-up. We have 3 waves. And people with low scores have a faster cognitive decline compared to people that have ideal cardiovascular health. And this is mainly for executive function, performance, and global cognition. The fact that cardiovascular health is related to executive function is something that makes a lot of sense, because executive function is usually compromised in the presence of vascular disease, cerebrovascular disease. If you want to give some weight to our finds around people with higher life essential aid score have a slower cognitive decline, have 42% slower cognitive decline compared to participants with lower score. And people with intermediate scores have a 42% lower cognitive decline compared to participants with lower score. So for you to have an idea of the weight of the association. This work is currently under review, and I hope it's going to be ready for you to read soon. In our, when we see the association of each metric with cognitive decline, we saw association mainly with body glucose categories and cognitive decline, and blood pressure categories with cognitive decline, showing that people that have better control at baseline of these 2 risk factors, they have a slower cognitive decline. And I think one thing that is really cool about the work that we've been doing in Brazil is the fact that we can take a look in some subgroup differences. So we try, since it's a huge sample, we try to see if there is a difference in the rate of cognitive decline in people younger than 60 years or older than 60 years. By sex and race. And we found a positive interaction for all these socio-demographic risk factors in a way that older people, male and Black people have a faster cognitive decline compared to the other categories, showing that probably these subpopulations are at higher risk in the presence of worse cardiovascular health. And another study that I would like to emphasize is about the association between ultra-processed foods and cognitive decline. This is a study that is published this year, and it's a work by Natalia Gonçalves, that is also a postdoc fellow in our group. To classify the presence of ultra-processed food, we use a Brazilian classification that is called NOVA, and it's been used all over the world. And we consider ultra-processed food all the food that were manipulated by industries and include sugar, salt, and oil, and also a lot of fat and other additives to make the food last longer, but also to improve the way that they feel. So people, most of the time, the food that is ultra-processed is very tasteful. This includes, for example, frozen pizza, frozen burgers, ice creams, the bread that we buy at the supermarket, all the foods that are already prepared that we buy in the supermarket. These are all ultra-processed food, and they contain a lot of additives. We have shown that people who eat a lot of ultra-processed food in the baseline of the Delta Brazil have a faster cognitive decline. And we also, the first quartile, the people that ate more than 20% of their calories coming from ultra-processed food have a 28% faster cognitive decline in global scores, and these numbers came from the quartile that we are using here. Another study that is related to cardiovascular risk factors that we've been doing, I'm going to come back to the brain bank again. We can collect the brain, but we are also collecting some of the arteries, the main arteries that we have in the body. Here we have shown the association between carotid artery stenosis and dementia, showing that people that have higher stenosis, and this we measure using morphometric measures, have a 2.3 higher chance of higher odds of having dementia in our sample. And we are expanding this study currently under the funding of the Alzheimer's Association, showing the association not only with the carotid arteries, but other arteries like the aorta, coronary arteries, and also the cerebral arteries. And we are also expecting to have some results soon. And I'm going to end the presentation, talk about dementia prevention. As many of you know, the influential work of Professor Gil Livingstone to University College London. She's part of the Lancet Commission, and this commission estimated that around 40% of dementia cases in the world may be attributed to 12 risk factors. And they built this very interesting graphic showing the 12 risk factors in a life course epidemiology approach. I'm a geriatrician by training, so I think this is really cool. We have early life factors, that is basically low education. We have midlife factors that include hearing loss, traumatic brain injury, hypertension, and alcohol use and obesity. And you have late life factors like smoking, depression, social isolation, physical inactivity, air pollution, and diabetes. So if we sum up the influence of these factors, we estimated that if we abolish all these factors, 40% of dementia cases will disappear from the world. Of course, it's impossible to disappear all these risk factors, but gives you an idea of the potential for dementia prevention in the world. So what we did is that we repeat this methodology using data from the ELSE Brazil study. And in Brazil, the potential for dementia prevention is higher compared to the Lancet Commission that have world estimated. So we estimated that 48% of dementia cases in Brazil are attributed to the same 12 risk factors. This was published last year. And the four most important factors here in Brazil is education, is the most important factor, and it's related to around 7.7% of dementia cases, followed by midlife hypertension, 7.6% of the cases, midlife hearing loss, 6.8%, and midlife obesity, 6.6%. So looking at the four most important factors, you already have an idea that dementia prevention is mostly done in the beginning of life and middle age. So that's something that usually people, lay people don't have this idea. They think that dementia is something from old age, but it can manifest most of the times when you're old, but the risk factors needs to be tackled early in the life course. And we also have the chance to look if there is any difference of dementia prevention by race. We didn't find this here in Brazil, but the proportionality of prevention is the same, about white and Black people, but the order of the risk factors change a little bit. Less education is more important in Black people, followed by hypertension and hearing loss, while in white people, the most important factor is hypertension, and less education and hearing loss follows in the second position. So this could be maybe important to guide public policies when we're thinking about some neighborhoods that have more different race composition. But also what's really interesting is that Brazil is divided in regions, and we have our south and southeast regions, that these regions here in Brazil, they are considered richer regions, because they concentrate most of the best schools, hospitals, the best opportunities for jobs, while the northeast, north and center-east of Brazil are considered the poor regions. And the potential for dementia prevention is higher in poor regions. And also the order of the factors differs by region. For example, in poor region, less education is the most important factor, while in rich regions, hypertension is the most important factor. So this is part of the first report that the Minister of Health in Brazil invited us to do. And I hope that this is gonna help create policies that are directed for dementia prevention, and they vary by Brazilian regions. This is a work that we have done with Professor Gil Lipson. She helped us a lot with this work, and here is she presenting our work, including hers, at a Brazilian conference last year. So to end my presentation, I would like to talk about the latent fingers. As many of you know, the finger study is the first randomized clinical trial for dementia prevention. It's a 2-year multi-domain program that includes diet, exercise, cognitive training, and vascular risk control. And it was done in Finland. And there they show that the intervention group had a better scores in the end of 2 years in executive function and processing speed, no improvement in memory. So again, having improved in executive function and processing speed is also very related to probably improving vascular health. And what Professor Mia Kivipeto did is that she expanded the finger model to other countries. And we are very proud to see that most of the countries here in Latin America are now have an ongoing study that is the latent fingers. Latent fingers here is Lucia Crivelli. She is the Argentinian professor that coordinates the study. Here is our meeting in Cartagena last year. We are going to regroup again tomorrow in Belo Horizonte here in Brazil. And we are very proud of this study because we are conducting studies in 12 countries here in Latin America. We expect to recruit 1,200 people from these countries, so 100 people from each country. And we are implementing the finger model, but we are adapting. So, for example, for physical exercise, of course, we do weight training, but we also do Zumba classes in most countries. For diet, it's a mind diet. It's based on the mind diet, but we don't eat salmon or berries because we don't have here in our countries. We adapt to the things that we have here. So I think this is going to create a very interesting, it's already creating because it's already going on since 2021. It's going to create a very adapted finger intervention for our region. And another thing that is being a landmark for this study is that most clinical trials, they only include white people. And here in our region, they have a lot of ethnic diversity. So here we have the map of the Latin fingers, the countries that are part of the Latin fingers. And you see some countries that have mostly white people like Argentina and Uruguay. But we do have a lot of miscegenation like in Brazil, and a lot of mestizos that are people that are descendants from the Indian population in other countries in Latin America. So it's going to be a very important clinical trial to bring diversity to this field. And unfortunately, it's true in all Latin America, our population has a high cardiovascular risk profile. Here we have the prevalence of, for example, obesity, abnormal blood pressure, glucose, lipidemia, physical inactivity. So it's really, really prevalent. In some countries are worse, like Mexico. Others are a little better, like Colombia, but we still have a high prevalence of cardiovascular risk factors. So for all these, we expected to have a larger effect of this intervention in Latin America compared to what they found in Finland. So we are very excited to see the results. The trial was extended and now it's going to be 24 months too. And it's supposed to end by 2015 when all the centers complete the intervention. So to conclude my presentation, I would like to emphasize that vascular dementia and pathological comorbidities are very common. I think it's not only low-middle income countries, it's everywhere. There is a high prevalence of cardiovascular risk factors in our region, a very low cognitive reserve, and this brings a great potential for dementia prevention in Brazil. And I think for what we see from the risk factors profiles from Latin figures, it's also true for the whole Latin America. So thank you so much for your attention, and I'm open to answer any question that you may have.
Thank you. That was such a great presentation with lots of really great, important information. Ooh, and you already have a question.
Oh, no, I have a question. I have two questions, Claudia. One is a short one about the fingers studies, the physical activity portion of the intervention. I'm surprised you use weight training. Isn't aerobic activity what you really want to promote brain blood flow in people?
So, yeah, it's complex, Loretta. You're supposed to have weight training, aerobic training, and also flexibility. So it's a very intense program.
Multi-component training. Yeah. Is there any dual task exercise involved in that where they have to, you know, do something cognitive while they're doing something physical?
That's interesting for you to say. So I said that we adapted some of the aerobic interventions, for example, we do Zumba here. But what happens that part of the cognitive training is in a computer program. And that was a huge problem in our region because most of the people don't know how to log into the system, how to use the computer. So what we are doing is after they have to come to the center 4 times per week. So after they finish the physical activity, we bring them to the computer room and we teach them how to use the computer. So it's not a dual task, but it happens in sequence.
On the other hand, Zumba class, having taken one Zumba class, that's a cognitive challenge if you have to follow an instructor and look in a mirror at the same time. So that was a wonderful presentation. Thank you.
Thank you.
And just piggyback on that question. So do you always have the cognitive training after exercise? Or is it sometimes mixed where the cognitive training is before exercise?
So thank you for the question. I have the opportunity to clarify. So in the beginning, every time, because they know it's really, really amazing how much people have illiteracy for computer and logging in the system. But the program they are supposed to use also at home. So once they have proficiency on that, they don't have to do it after the training.
Okay, because there's some evidence that exercise is a cortical primer so that they could perform better and retain that learning longer. So it'd just be kind of an interesting component of the study.
Yeah, we could compare that. In fact, we didn't design for that. It's just like the logistics of how difficult it was in the beginning for them to learn. Luisa?
Yeah, I have a question. First of all, I'm so happy to actually see a Brazilian researcher here. I am from Brazil.
Oh, really?
Yeah, that being said, I was just wondering, for the first part, you were mentioning how you get all the brains to do research on the tissue. Where do you get them from? I'm just thinking about like SUS systems and how like more people who are like underprivileged are gonna access the public system, and then would that means that we have easier access to brain that comes from SUS? Or is it the same? Like, I know the autopsy is quite different, but like, do you have a different average of people who actually let their brain being used for research when you compare like people who come from private or public insurance?
Yeah, thanks so much for your question. Yeah, you're kind of right, because here in Brazil, so for everybody to understand, we have public free access to health, but doesn't work very well. So most people have this access, but they also have private insurance. So when you die in a hospital with a private insurance, you have a higher chance of getting a death certificate because they know better what happens to you. So probably we have an over-representation of poor people in the brain bank. But you know, Luisa, when we compare our social demographics with the social demographics of people that die in the whole country, it's very similar regarding age, sex, race. So there is some mismatch, but it's not that much because very few people have access to private insurance here. And the other thing that happens is that some causes of death, for example, cancer, usually when you die from cancer, you have a very well-defined cause of death. And we have a few cases of cancer compared to the general population in autopsy service for sure. And a little bit more of cardiovascular disease maybe. But at least there is not a very different numbers for this cause of death.
Okay, thank you. I do have one more question. When you were showing the schematics that had like 12 factors, I think, that they're more important or determinants for the diagnosis, you had depression and social isolation. So I was just wondering, how do you actually measure social isolation? Like, because that's not a diagnosis. I feel like all the others were diagnoses that you can actually have it, but how do you do the social isolation part?
So there are some questions in the ADRD Brazil study regarding how frequently you see other people, including family, friends, and if you have exposed. So we use this question. And the definition for social isolation, we copy from the Lancet Commission because the authors are with us, Gil Lipson and Nahid Mukadam, and it's very strict. To define social isolation, you had to not see anyone for 1 month. So the prevalence of social isolation in Brazil is very, 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 very low. So it's a risk factor that has a very low prevalence. But the definition is very strict, in my opinion. Okay,
and is there a chance of having like comorbidities related to social isolation? How do you like classify? Okay, I understand they have a strict way to classify it, but couldn't it be related to so many other comorbidities?
Yeah, that's a very nice question. I chose to not give too many formulas, but the population attributable fraction takes in consideration 3 things. The relative risk that comes from meta-analysis that we call from last commission, the prevalence of each risk factor that you use the prevalence from the ADRD Brazil study, and the third factor is commonality. That's exactly what you're saying. So of course, people that are obese, probably they are physical inactive, they have diabetes. So there is a lot of commonalities among factors. So we calculate this using principal component analysis. This is one of the numbers that are plugged in the formula to calculate the population attributable fraction.
Okay, thank you. I do have one more question. I'm so sorry. I've never even heard of this study, and I think it's so exceptional to have a research that big being done in Brazil. So knowing that all the information we have from our country, do we have anything specific like in CAPS for any type of prevention, intervention kind of thing in the public system? Or like, because we have all of this data, have we been doing anything with it or not really?
Yeah, that's a great question. Thanks, Luisa. So I'm very happy that the Minister of Health in Brazil asked us to do the first report. So the prevalence part is going to be is one of the chapters of the report. The risk factors work, that is the path work, is going to be another chapter. And I think this is going to provide a map of the problem in our country because we don't know yet. And after that, we can implement some interventions because we don't have enough money to tackle all these risk factors. So probably we can tackle different risk factors in different regions. We are very hopeful that's going to be translated in public health policies that are going to change the way that we diagnose, treat, and prevent dementia in Brazil. But that's a dream. Yeah.
Yeah, that's for sure. Well, thank you.
It's my pleasure. Nice to meet you.
Nice meeting you.
Ella?
Hi, Claudia. It's really great. I heard about the study in Nairobi, right? But to see the breadth of work that you've done, it's really incredible. So congratulations. I just wanted to ask about the brain bank more as a follow-up to Luisa's question. So these are people who opted before they die to. How did that work? Or did you prospectively ask for consent? And if that's the case, like how do you navigate that? It's a very tricky, I guess, consent process, and how do you approach the participants? That's one thing, we are considering in our study, but it's just really hard to wrap your, brain about asking for brains, I guess.
Yeah, so the thing that we do here is very different because we take advantage of the logistics. So currently I'm in the medical school, and the autopsy service is just the lower floor here. So it's very close to our lab and everything. This is useful because we have a very low post-mortem interval, and that's great for the brain analysis. The fact is that we never seen these people before they die. So what happens is that the family comes here to get the death certificate, and they have to wait until the autopsy is done. So they usually wait for 4 hours here until everything is done, and they can have the death certificate to bury the family member. So while they wait, we explain the study and ask if they want to donate the brain for study. And that's why we have so many people with normal cognition. And yeah, so, and we do with them a questionnaire that lasts around 1 hour. And we ask about the previous disease that they have. We do a post-mortem cognitive evaluation with the family member using questionnaires that are designed to be applied in an informant. And that's how we've been doing the last 18 years.
That's incredible, and what a great opportunity to be able to do that. And so, are you able to, since you said most of it is public, right, from public hospitals, do you have access for their medical history through the medical records, or to be able to, look back and see their history?
Yeah, that's something that we tried many times, but it's very decentralized here. So
Right.
We are not able to do that, at least until now.
Mm-hmm.
Yeah, that's a huge problem. We have some donations during life, so people that have advanced dementia and then want to donate the brain. You also receive this kind of donations, but they are like less than 1% of our cases.
Right.
And then from these people, we have a complete case. Some of them have neuroimaging, but yeah, 99% of them don't have.
Great. Well, thank you so much, and it's nice to see you again.
Thank you. Nice to see you too.
Thank you so much for joining our seminar series. We really, really very much appreciate it. And we look forward to seeing more of your publications in the future. And please, everyone, join us at our next seminar session in 2 weeks.
That was great, Claudia. Thank you.
Thanks so much. Very nice to meet you all. Bye-bye.
Kiki.